Oh,
And then, yeah, okay.
all right, welcome everybody. As you can tell, I'm pretty prompt. So I know meetings usually start like 10 minutes after you're supposed to start, like lectures. But I like to start on time also because I have to go be in my office at 1 o'clock to patients. So welcome everyone. So this is a lecture I like to give every year. I give a few, multiple, across many different avenues here at HMH, but I think one of my favorite, in the top 10%, is the urinalysis lecture, because I think you don't really get to see enough of that in your training, because most don't come from programs where they view urinalysis as a very important finding in clinical practice. That somebody in the lab does it, but nobody really does it correctly for the most part. So I'll just get going. I always like to start with some questions to trigger people's thought processes. So 25-year-old female with diabetes for 14 years. She comes to your office for an evaluation and follow-up. Her blood pressure has been high recently, and she admits to poor compliance in regards to her diabetes. And 1 year ago, she had a little microalbuminuria, and she was given an ACE inhibitor, but she never filled the script. Okay, that basically tells you ACE inhibitor shouldn't be the problem here. But review systems is unremarkable. Her blood pressure is a little high. Exam is otherwise not very significant. She's not taking any medications. And this is the lab results. So you do some blood work. She's in your office. Her creatinine's normal. BUN is normal. Hemoglobin's normal. White count's normal. Platelets are normal. Liver function tests are normal. But look at the and the chest x-ray nitro in there, EKG is all normal. So you got the picture. EKG normal, labs normal, she's got hypertension. And this is the urine analysis. She's got 2+ protein, 1+ dipstick blood, and she has a microscopy that shows 3 to 5 WBCs, little red cells, dysmorphic red cell. And by the way, for any of those who take exams and boards, this is how they report urine analyses for the boards, okay? And the ultrasound showed normal echogenicity. So the question is, what are you supposed to do? Any thoughts out there? You do renal biopsy, you do a Doppler of the artery, renal arteries, you get a serum renin aldo level. You start the ACE inhibitor that she should be on for her microalbuminuria, or do you send it to a urologist for the hematuria? Any thoughts? What's that? Right, so renal artery Doppler would be okay if her urine analysis was unremarkable. Maybe not even okay, all right? So this is what you missed, okay? Red blood cell, this two dysmorphic red cells is a red cell cast. So I want to raise a hands here who have been working across the continuum of hospitals anywhere, in New York, wherever you come from. Anybody see red blood cell cast reported on the urine analysis test? Anybody here? So I'm going to come out and, very strongly and say that means the urine analysis lab is not good, plain and simple, because that means you've never seen glomerulonephritis. There's no hospitals who have seen glomerulonephritis. I can tell you in the best hospitals in the world, we used to see red cell casts reported all the time, okay? Red blood cell cast is a renal emergency. That's the point of this slide, okay? This patient should have a renal biopsy. And if you miss it, you're going to cause this lady to go on dialysis. We actually had a case here in the clinic. This was a real case, by the way, of a case down the street that they had asked me to see in follow-up for other reasons. But it was missed, and the patient came back with a creatinine of 4. And she had pretty scarred kidneys, and she had lupus. And we missed it because the urine showed blood, but people poo-pooed the urine analysis. And because the creatinine was normal. So the purpose of this slide is for the boards, any test. You see dysmorphic red cells, I'm going to show you pictures of it, which are red blood cell casts, okay? That's a renal emergency. It should require renal biopsy, okay? And that's the answer. I won't read it. You can read it and get your slides later why the answer is renal biopsy. Question 2. 18-year-old, she comes into your office for a low extremity rash. She has abdominal pain and some arthralgias for a few weeks. So exam, she's hypertensive, and she has these palpable purpura of the lower extremities, okay? Creatinine's 1.4. Her C3, C4, ANA were all normal, okay, looking for lupus. right? Hansel stain is negative. Anybody know what that's used for? It's used for interstitial nephritis. It's the stain that you use when you order urinary eosinophils, okay? So that's the stain that they use. So that was negative, all right? Renal ultrasound shows some increased echogenicity, which generally means something's going on in the kidneys when you see that, by the way, okay? And the urine analysis, again, 2+ protein, 2 dysmorphic red cells per epithelial field. And the question is, what's the diagnosis? HSP, lupus, AIN, post-infectious, MPGN. Probably nobody even knows what MPGN is, so we probably can cross that one off. We'll get to that. Post-infectious, allergic, lupus, or HSP. The diagnosis is HSP, all right? Arthralgias, abdominal pain, and red blood cells in the urine with a slightly elevated creatinine. It's a clinical diagnosis. If you do the kidney biopsy, you'll see IgA on pathology. Again, this is how they report out urine analysis for any exam, board exam that you're going to see, okay? It doesn't matter that you've never seen it, and that's why I bring it up. Just because you haven't seen it doesn't mean it's good. It's not good for board's question. That's how they want urines to be reported in America. And if you haven't seen it, that means that if you haven't seen dysmorphic red cells, okay, you should, and I'll show you pictures of that. So that's the answer, HSP, and that's the explanation. Question 3, and we'll get into some didactics. 29-year-old female presents to her gynecologist for dysuria for 3 days. You're like, okay, no big deal, right? Temps 100, 0.7, a little flank pain, suprapubic tenderness. You're thinking UTI, no big deal, right? Creatinine's normal. UA shows 5 to 10 WBCs, 1 to 3 RBCs. She gets a dose of gentamicin. She gets put on Bactrim. And then you do labs 1 week later, and you look at the UA, and it shows no white cells, no red cells, creatinine bump, though, 1.5, complements were normal. What does she have? Okay, so going back on the history, she's got a UTI, right? Maybe some pyelo. You give her a dose of Gent, you put her on Bactrim, and she comes back and her creatinine's higher. What does she have? So the answer is pseudo-hypercreatinemia, okay, from the Bactrim. Now, everybody says, you know, so why is that? So could she have, and you can read the explanation, what, she probably doesn't, she's probably not obstructed, right? She's a young lady with pyelo. Why should she be obstructed, right? Aminoglycoside toxicity, 1 dose of Gent won't do it, okay? In someone who's got normal renal function, you usually need several doses. AIN, yes, but usually the boards is not there to trick you, by the way. They're not. They want you to know knowledge. Or any exam you take, for the most part, unless you work with some, educators that try to trick you, okay? But for the most part, the boards aren't there to trick you. So if they thought that this was an interstitial nephritis, or if you thought this was an interstitial nephritis, you have to have a rash, you have to have peripheral eosinophilia, and they should give you that information, okay? They're not there to, now, could it be? Anything's possible. Yes, it could be. But the likelihood of this is about what's the most likely diagnosis. And pseudo-hypercreatinemia. So Bactrim has trimethoprim in it, right? Trimethoprim gets into your kidneys, and your kidneys got to get it into the tubules. It secretes it. It's an exchange. So instead of taking your kidney exchanger, instead of taking creatinine and putting it into the urine, okay, it takes trimethoprim and puts it into the urine. And so what happens is the creatinine stays back in the blood. And that's why you get a pseudo-hypercreatinemia. So your creatinine goes up a little when you give someone Bactrim, but that doesn't mean it's a disease state. Doesn't mean that they have anything wrong with that, okay? And usually we accept about a 0.5 milligram per deciliter increase, okay? Got it? All right. So that's the answer. You could read about it at your leisure. So when you do a urine, okay, it has to be in a clean container, makes sense, okay? You want to get a clean catch. You should look at the urine within a few hours, 2 hours in particular, okay? And there's some, you should look at the urine under room temperature, okay? And when you look at the urine, there's 3 components to urine. What does it look like? What color is it? You want to dipstick it, and you want to see, is there blood in there? Is there protein? Is there nothing? And a microscopy. Like when you look at the cells, what kind of cells are there, okay? So in bad hospitals, which don't look at microscopy well, which is about 95% of the hospitals in the United States, the dipstick, okay, will be more sensitive than anything else. So I'll give you an example. Let's say I come in the hospital with cellulitis and my urine analysis shows no dipstick protein and no dipstick blood. I will rely on that more than any microscopy evaluation by somebody who doesn't look at urines for the most part, and they report out something. Okay, they follow what I'm saying? So if the dipstick is negative, because it's very sensitive, and we'll get to that, the dipstick is negative for protein and blood. That means by definition, for the most part, they don't have a glomerulonephritis. And that's what you don't want to miss. Okay, so let's do one more question, then we'll get to some pictures. 29-year-old male comes to your office for low back pain, right? And his exam shows hyperpigmentation of some inguinal creases, and the sclera are brown. That's weird, right? Shouldn't be brown, they should be white. X-ray shows some calcification on some intervertebral disc. Creatinine is normal, hemoglobin is normal. UA shows no protein, no blood. So that's the color of his urine. This is a real case, by the way. I'm just what the color of his urine. It's brown. So what's the diagnosis? Okay, what's his? Alkaptonuria. Okay, and it's an autosomal recessive disease. Okay, and this is the pathophysiology, and it basically causes elevated homogentic acid levels, and you get brown discoloration of your sclera, and it's called ochronosis. But I throw this slide in there, so look at the urine, okay, especially when you're looking for blood or different kind of disease states. For example, one more question on color of urine. 29-year-old female from Africa comes in for a physical. She has lymphedema in her legs. Legs are like this, really fat lymphedema legs. Unusual, right? Creatinine's normal. And by the way, the urine analysis shows when they want to show that there's an active sediment, meaning that this is glomerulonephritis, they're not going to give you 2 to 3 red cells. It's going to be 10 to 20 red cells per high power field. And they're going to show red cell CAS, hemoglobin CAS, et cetera. 1 to 3 is considered normal for the boards on any exam you take. Okay, so they'll get thrown off by that. And urine protein to creatinine ratio is something that they expect you to know as residents, fellows, and medical students. And basically, when we do a 24-hour urine collection, right, we order 24-hour urine for protein and creatinine. What you need to know is that the average male and female will excrete 1,000 milligrams per day of creatinine on average, okay? And 1,000 milligrams is a gram, okay? So if I measure your 24-hour urine, and actually I do this. I measure, whenever I do 24-hour urine for anything, I always do creatinine. And the reason is because I want to know if it's an appropriate collection. Okay, so you should still about 1,000 milligrams a day in someone who's got normal renal function. So so that's the reason for G. So gram of creatinine. Okay, so 0.1 grams of creatinine is how much? 100 milligrams. Okay, so what's normal 24-hour urine excretion of protein? Anybody know? It's less than 150. That's what normal should be. So if I measure your 24-hour urine for protein, 24-hour urine for protein, your 24, it should be less than 150 milligrams. So that's why that's 100 milligrams per gram, which is normal. It should be less than. So if this ratio was 1.0, that's 1,000 milligrams per gram. You got to put this in your head because on the boards and on the exam questions, that's how they report it, by the way. You got to know that. Okay? They oftentimes don't give you the 24-hour collection. And that's the color of her urine. So a lady from Africa comes, and this is the color of her urine. These are real cases, by the way. Okay. What's the most likely diagnosis? UTI, minimal change, cystinuria, filariasis, CIN. Good. And that's the reason. It includes the lymphatic channels, lymph spills into the urine and gives you yellow urine. So when you look at urine, look at the color, okay? And this is a slide that kind of reviews the different causes of discolored urine. So this is a slide looking at, I don't have a pointer, sorry, normal red cells in the urine. This is a dysmorphic red cell, like I showed you for the boards and the prior slides. See these little buds here off the red cell? It's the red cell trying to go through the glomerular basement membrane, and it splits, okay? And so when you have inflammation of the glomerular basement membrane, that blood will try to get through the GBM, and it splits on itself. And that's a dysmorphic red cell, or called a acanthocyte. So that's a sign of glomerular injury. It's a renal emergency. Okay, another sign, see that with the little arrow? That's a dysmorphic red cell. All right, that's a picture of white cells in the urine. Okay, so the reason I'm showing these pictures is when you look under the microscope, because nobody looks anymore, they just look on the computer. Nobody goes to the lab. But this is what they expect you to know. These are normal white cells in the urine. That's a urine eosinophil, okay? Those pink granules. And a cast. What's a cast? And you've heard of cast, but what is a cast? It's cells, multiple cells in a matrix of hyaline, okay? So this is a matrix of hyaline, and you have white cells in there, and that's a white cell cast. And you usually see that with what? Infection. Very good. So, and they'll present a case. Someone with pyelonephritis, they'll show a case. They'll tell you, a 50-year-old lady comes in with flank pain, fever to 103. She's been put on antibiotics for UTI, and they'll show you a picture. And you got to pick out the white cell cast would be most likely going with that patient. That make sense? Okay. That's another picture of a white blood cell cast. Okay. Usually you don't see white cell casts with glomerulonephritis. Okay. You'll see white cells with certain disease states, AIN, UTI, but you don't usually see white cell casts with glomerulonephritis. You see red cell casts, and that's a red cell cast, right? Those are red cells in a matrix, okay? And that's a sign of glomerulonephritis. If you're on the floors here and you see a patient with a creatinine of 3, the most important thing to know is that you have to know the etiology of why the creatinine is 3. But if you don't know, the one thing you need to always rule out is glomerulonephritis. As a nephrologist, that's the one thing I always need to rule out. Okay, an active proliferative glomerulonephritis, because if you miss it, patients will progress and wind up on dialysis. And then if you leave it too long, and that could be defined by a week, there's no chance of recovery. Okay, another picture of a red cell cast. Okay. I want you to put this in your memory banks and don't forget it. Okay, hyaline cast, that's what you usually see reported in 95% of hospitals that don't look at urines and don't care about urines. That don't mean anything, okay? It's just normal, okay? So in good labs, they don't even report it because it's a normal finding, okay? So I probably have hyaline cast right now. Doesn't mean anything, okay? So why report something that doesn't mean anything, okay? So now, that's not a hyaline cast. Is there any cells in there? The answer is no. You don't see any cellular component, right? So it's not a red cell cast. It's not a white blood cell cast. It's a hemoglobin cast. So it's just hemoglobin that's coalesced into a matrix. And it's another sign that you could have a glomerulonephritis. So red cell cast and hemoglobin cast, for any exam, for any patient care issue, that's a renal emergency, okay? Granular cast. See these little granules? That's a granular cast, right? There's no true cells inside the cast. And usually you see that with what? Granular cast. ATN, very good. And there's another picture of a granular cast. And look, there's no cellular component in that. And that's a muddy brown granular cast. And that's what they typically report for any exam questions for ATN. Okay, waxy cast doesn't really mean anything. It's sort of like a degradation of a granular cast. I just throw it in there. That's a broad cast. There's no cellular component. If they ever show you this for the boards, it's a broadcast, no cells in it. It's a sign of chronic renal failure. The thought is that it takes more time for the urine to flow through, and these hyaline casts become bigger, and they form a broadcast. So if you see broadcasts for the boards or any kind of exam, it's a sign of chronic renal failure. Fat globules in the urine. What do you think of fat globules? Fat in the urine should be what? Nephrotic, very good. So anything with more than 3.5 grams per day, okay? So those are, whether it's free fat, fat globules, or Maltese cross, which is sign of a cross, okay? Apparently it's described in Malta. I'm just telling you, that's why they call it a Maltese cross. And fat polarizes, by the way. So on the polarized light, fat polarizes, under polarized light, fat will polarize, and therefore that's why you'll see these fatty casts, and they show different pictures of. I have different pictures of this. These are fatty casts also. Fatty cast also. That's really it for casts. But any questions on casts? Okay. So now fatty casts. So if you see fat in the urine, you now have to know diseases that will present with nephrotic syndrome typically. Membranous, FSGS, minimal change disease, patients with far advanced diabetes, okay, would present, you have to have nephrotic range proteinuria. So usually diseases like even ANCA vasculitis, you don't usually see fatty cast. They present with a proliferative sediment, usually 2 to 3 grams, but not nephrotic range type proteinuria. Okay, so you see other things. Oh, go ahead.
So when we order UA, is there a specific order that we can place where we can emphasize, can you please look at?
Well, you can. You have to go down and no. The answer is no. And so you have to go, and even in very big centers, I won't name names. That's not my style. But even in big centers, they don't do this correctly. I can tell you that. So there's only, in my estimation, I'm just guessing, there's only probably maybe 15 hospitals in the country that really look at urines and have the same diligence to urine analysis reporting that you're supposed to have. But that's how the board reports out UAs. You got to see the whole different in hospitals that really spend a lot of quality emphasis on urine analysis reporting. It's nothing like you see in our labs here. And I would say, and there's no hospital in New York that I've seen either, by the way. Okay, so and so the other issue is you have to also know that a red cell cast is such a emergency that in real labs they have to be double reported. Like, in other words, it has to be confirmed by 2 people who only look at urines all day long. There's actually a special way to look at urines, and also reporting out urines. You see some stupid reporting here, like you'll see something like 38 white cells per habit field. There's no such thing. Okay, so it's supposed to be there's a grid that you're supposed to report these out on. It's supposed to be less than 1, 1 to 3. There are standards: 3 to 5, 5 to 10, 10 to 30, 30. There are standards of how real expert labs are supposed to report out urine analyses. So if you go to any hospital that reports out urine analyses just by some haphazard number, you know that the lab doesn't know exactly what they're doing, because it should not be reported that way. I'm just telling you, there's standards to this. And so for the boards, that's how I guarantee you could look at any board question you want. You show me, I dare you, find a question that doesn't report out urines like that. And that's why this is a very important lecture for you guys to not only know how to treat patients, but also get questions right for the boards. Okay. So crystals. Crystals are normal in the urine for a lot of patients. It could signify disease, but calcium oxalate crystals could be normal. Okay. There are 2 types. There's a dihydrate crystal, the envelope, they call it the envelope-shaped crystal, and the calcium oxalate monohydrate crystal. Okay. A 4-sided crystal is uric acid. So if you're a little overweight, your propensity to gout, you can form uric acid crystals in your urine. Doesn't mean you have a disease, but you're more likely to maybe form uric acid stones. Okay. But 4-sided crystal is uric acid. That's another picture of a uric acid crystal. Just remember, you only have 45 seconds to get questions right on the boards and read the question, answer the question. You only have 45 seconds. So sometimes it could be the quicker you can relate to pictures and thought processes, the better off you'll be. Crystals polarize. Fat polarizes, crystals polarize, and garbage polarizes, meaning contaminants in the urine. So that's a 4-sided uric acid crystal on the polarized light. Sometimes you can't tell exactly what it is, so you polarize it, you move over the microscope, you polarize it, and that's a uric acid crystal. Now that was 4-sided, this is 6-sided, okay? That's cysteine, that's diagnostic. There's nothing else that causes 6-sided crystals in the urine. You don't have to, I told you, nephrologists, we're not that smart. So 4-sided uric acid, 6 sides is cysteine, it's easy, okay? So if you see this on the boards, okay, it's cystinuria. There's nothing else, okay? And that's why I do 2 slides in there, because they ask this a lot. Because there's nothing else. You can't. We used to write back to the boards all the time. We're like, no, you were wrong. We've seen this. Believe it or not, you can't write to the boards and tell them their questions are wrong. I don't know if you know that. But we used to write every year. We used to write 2 or 3 answers, because my mentors used to write some of the questions. So we used to argue about how you write these questions. But you can't argue this. You're like, well, it wasn't 6-sided. Yes, it is. It was 6-sided on the question. That's why the boards tends to ask you very specific questions that are not debatable. Okay. All right. And that's a coffin lid crystal, magnesium ammonium phosphate. Okay. Coffin lid crystal, struvite, comes with patients who have staghorn calculi, recurrent urinary tract infections. Okay. Magnesium ammonium phosphate crystal again. Coffin lid crystal. So if you see coffin lid, got a picture. It looks like a coffin lid, I guess, right? But that's, somebody named it that. But anyway, that's a struvite crystal. Think infection, and that's Bactrim. That's a Bactrim crystal. You take too much Bactrim in a concentrated urine. It looks like a fan. Okay, so it's a Bactrim crystal. And that's dye, contrast. Okay, so contrast can give you a crystal as well. All right, and this is garbage, squamous cells. So whenever you see squamous epithelial cells on a urine specimen, okay, that means that it's a contaminant, because men should not have squamous epithelial cells in their urine. Okay, that's why men's urine is a lot easier to look at than women's urine. I hate women's urine in the office because they were always giving me vaginal contaminant. Okay, so you have squamous epithelial cells in the urine, and then you can't interpret the urine analysis. For the boards, they won't give you that as a confounding variable. You only see this in private practice. It's important in the hospital, though. For example, if you do a urine and the person in the lab reports squamous epithelial cells, what I do is I say it's a vaginal contaminant, it's not interpretable, so I can't interpret what you're showing me. So therefore, if you say you do have microscopic hematuria, I don't work it up. I say, give me a clean catch at some point, so I'm not responsible for this, okay? Because you don't want to act on things that's a contaminant, basically. That's not accurate, okay? And that's a pinworm. Just think of it, everything that's in the urine is not always, shouldn't be, it's not a clean catch. So if you see things in the urine that don't make sense, a lot of times it's a contaminant. Hematuria, what is hematuria? By official definition, greater than 2 red cells per power field. It's very sensitive. That's why I said sometimes I trust the dipstick more than I do the people looking at the urine, okay? How do you tell hematuria from a glomerulus injury versus a plumber's problem? So one is the smart kidney doctors like us, right? That's our problem if it's a glomerulonephritis. And then you deal with the plumber's hematuria, the urologist's hematuria. So how do you tell the difference? Well, you spin the urine down, okay? So you centrifuge the urine. So if the sediment, that's the stuff at the bottom, is red, that's real blood. That's blood in the urine, okay? So you spin it down, you look at the tube, and if the stuff at the bottom is red, that means that it's real hematuria, and therefore you have to think, boy, this could be coming from the glomerulus, okay? If it's not, if you don't have a sediment that's red, and the supernatant, that's the fluid on top, you dipstick it, and it's negative for heme, then you have to think the things that can cause contaminant, like beets is a big one, okay? If you eat a lot of beets, it'll turn your urine red, okay? You could try it. If the dipstick is positive for heme, the supernatant is positive, then you think myoglobin or hemoglobin. And they do ask questions that are derived from this process on the board. You know, they'll be like, okay, you spin a urine down, sediment is, there's no sediment, but the dipstick is positive, and then you have to think, oh, this could be, someone who got a massive blood transfusion and hemoglobinuria, somebody who has rhabdo and from myoglobin, so you have to know this slide. Okay. So another way to tell blood that's coming from the plumbers versus the nephrologist is if you have dysmorphic red cells for the boards, that's a glomerulonephritis. Okay, so if they present the case on the boards, UA shows 10 RBCs per Apella field, but they don't give you dysmorphic red cells. They don't give you, usually, if it's not a real question, they're usually trying to get at that this is a urologic issue. Okay, not always, most of the time. Okay, so blood clots is almost always, if you have a patient who has blood clots, it's almost always urologic bleeding. You never get blood clots from glomerulonephritis. Okay, and by the way, that's the workup for blood clots and hematuria. It's CT urogram, not ultrasound. Well, why do I see ultrasound? Because urologists order ultrasound. It's too hard to get a patient from their office into to get a CT urogram, but that's not the right workup, and you miss tumors that way. So the proper workup for anybody on the boards and in real life is CT urography, urine cytology, and a system. So me, I'm 54 years old. If I have blood in my urine, I shouldn't have blood in my urine. I should get a CT urogram, urine cytology, and a cystoscopy. Okay, not an ultrasound, not a Doppler, not repeat the urine and wish it goes away. That's what my own partners sometimes wish these things. So that's the workup, because you're not supposed to have blood in the urine. Okay. But for anything else in terms of like trying to figure out if something is nephrologic versus urologic, the nephrologic evaluation and concern would be if you have protein, it's usually glomerular, red cell cast, acanthocytes, or dysmorphic red cells. Pyuria, defined by greater than 5 WBCs per power field. They're not going to, it's too simple. How many of the medical students here with the medical students? There we go. We got a few medical students. Very good. So they even want to ask that to you guys. Okay. So if someone comes in, they have dysuria and a fever, you know, they don't have to say, oh, this pyuria is from UTI. That's too easy. Okay. So they're not going to ask you that. So I throw that one out. So the things that you need to know, that pyuria can be caused by other things, whether it's an interstitial nephritis from antibiotics, analgesic abuse, kidney stones, etc. When you dipstick protein, I just wanted to talk a little bit about proteinuria. Some clinical facts. When urine proteins are made up of different types of components. It's albumin, immunoglobulin, TAM phosphoprotein, all mixed into a 24-hour urine collection for protein. Just keep in mind that exercise is the biggest thing that I see in the outpatient setting, causing a little proteinuria of 500, 600, 700 milligrams a day. I already told you that less than 150 is normal. So if I have a normal, healthy person like yourself come in and you got 600 milligrams of protein, I'll say, my first question always is, did you exercise before you did the collection? Do you have a fever? So just think of, and you can get up to 1 gram a day of proteinuria from exercise. The gold standard, if you have 2+ dipstick protein or more, is to collect the urine for 24 hours. Okay, so if someone in your office has UA 2+ protein, you're supposed to do a 24-hour urine collection. When you have a known glomerulonephritis or diabetes with proteinuria, etc., you're supposed to follow them to see is their proteinuria increasing or decreasing. You don't have to do a 24-hour urine collection. The standard of care is to do a spot urine protein to creatinine ratio. Okay, so the new term, instead of microalbuminuria, is moderate increased albuminuria. Okay, because the general thought is if you call it micro, it means that it's not important, it's too little. So they want to change the nomenclature now to moderately increased albuminuria. And so basically it's 30 milligrams to 300 milligrams per day of albumin in the urine. Okay, whether it's a collection or a dipstick. And then anything more than 300 milligrams is severely increased albuminuria. That's how they want you to speak about it nowadays in terms of nomenclature. So proteinuria is bad to have in the urine for a lot of reasons, not just renal. From the renal perspective, you're more likely to progress the more protein you are. For most disease states, not everyone, but many of them. So if you have 4 grams of protein in urine, as a diabetic, you're more likely to progress than if you had 1 gram. That's just the general dogma. It's a risk factor for cardiovascular disease, all-cause mortality, non-dipping hypertension, which is what you get when you're supposed to get a dip in your blood pressure at night. So it's a risk factor for that as well. If you see 2+ protein in the urine, you should refer a patient to a nephrologist. I'm not looking for business. I'm too busy. But that's the standard of care. And just remember that the dipstick is primarily looks at albumin. So if you're worried about paraproteinemia, you should do the SSA dipstick. Okay, biopsy. So that patient that I presented that case, someone who has, the young girl, hypertensive, and she had red cells in the urine. How do you do a biopsy? So you send the patient down. That's what the slide's about. You send them downstairs. They biopsy usually the lower pole of either kidney. It doesn't matter which kidney, right or left, okay, because glomerulonephritis always affects both kidneys. Most patients will have the left biopsy because they sit on the table and they lay down on their bellies, and the radiologist, which usually sits at the right side of the table, will biopsy the left kidney of the patient. But it doesn't matter which kidney you biopsy, and they do the lower pole primarily because you don't have a lot of the blood vessels and everything else there. So that's why you usually do the lower pole. And you usually do the outside rim of the kidney. That's where all the glomeruli sit. The glomeruli of your kidney do not sit in the middle. So it's not like you stick a needle in the kidney, in the middle of the kidney. So we have radiologists. I've worked at all the places around the country. You stick a needle in the middle of the kidney. I'm going to get that slug, the best piece I can get. They stick it right in the middle. There's no glomeruli there. The glomeruli all sit on the outside cortex of the kidney, and that's what you need to tell. That's the histology you need, glomerulus, to tell us whether this is a glomerulonephritis or not. Because if you go too deep, you get only medulla, and it doesn't give you an answer. there was a lot of other stuff on this slide. You know, you got to be careful about when you do a biopsy. They can't be too hypertensive, because when you do a biopsy, by the way, all patients bleed. Okay, I was going to see the time-wise how we're doing. Okay, all patients bleed when you do a biopsy. So when you pull the needle out, you can't like hold pressure like you do when you're drawing blood. So 90% of people bleed. You just hope that it just coalesces on itself and it stops bleeding when you pull the needle out. And so that's why patients should not have a high INR. That's why patients can't be on the DOACs. They can't be on Coumadin or aspirin, et cetera, et cetera. The reason that all has to be out of your system, because when you pull that needle out, they're going to bleed a lot if there's any anticoagulants on board. When do you restart anticoagulation after you have a kidney biopsy? It's made up. There's nothing written. I've looked at this. There are some articles here and there about, you know, I did this. So the general dogma is that, say someone's on Coumadin for an aortic valve and you need to do a biopsy because they're in renal failure, and you take the needle out. You usually have to wait 24 or 48 hours before you can put them on anticoagulations. That's the kind of standard of care. Nephrotic syndrome, we talked a little bit about this proteinuria. What's the definition? Proteinuria more than 3.5 grams per day, hypoalbuminemia and edema, and then you have some combination of hyperlipidemia and lipiduria. Causes, I mentioned, these are some of the causes where you actually get nephrotic syndrome. Like, you know, usually, you know, IgA will not do this. ANCA vasculitis won't cause nephrotic syndrome. So Wegener's, PAN, all those active proliferative glomerulonephritis don't usually present with nephrotic range proteinuria. Complications of nephrotic syndrome, you can get dehydrated is a big one, because you're losing a lot of albumin, and then the tissue, you get leakage of fluid into your extremities. Protein malnutrition, you get hypercoagulable states. We've seen venous, arterial thrombosis, and especially when the albumin is less than 2. That's kind of what's been written in the literature. So if your albumin is 1.5, you're at higher risk to develop complications of hypercoagulable state. And patients are increased risk for infection, so we give them Pneumovax. The treatment is treat the underlying cause. Okay, so if they have membranous nephropathy, how do you treat membranous nephropathy? That's another lecture that you can come to. They're fun. These lectures are fun, by the way. That's another. You got to treat the underlying cause, otherwise the nephrotic syndrome won't go away. Okay, so but if you're doing everything you can, they still have nephrotic range proteinuria, then you put them on ACE inhibitors, loop diuretics to control their edema, etc. Oh, another question. I like questions. I like to throw them in the middle. Otherwise, it gets too boring listening to me for an hour. Question 6, 20-year-old male presents to your office with a 2-week history of facial, penile, lower extremity edema. No drug use, nothing crazy sexually, no diabetes. He has periorbital edema. His cardiac exam's normal, lung exam's normal, but he has pitting of his legs. Okay? So creatinine's normal, urine tox is negative, sodium's 140, 24-hour urine protein 10 grams per day. What's the most likely diagnosis? Okay, so you have a guy who's young, comes in with nephrotic range proteinuria, nephrotic syndrome. What's the most common cause of nephrotic syndrome in a young adult? That's what this question's basically asking you. What? Minimal change. If I presented this case as a 60-year-old male, same exact, just change the age, what's the answer? Membranous. Okay, that's why I threw this question in. Okay, it's a classic question. Okay, and that's you can read this later for the sake of time. Another question. This is a good one. 18-year-old male comes for a physical, no complaints. Okay, physical exams normal. Okay, and by the way, I always throw blood pressure. Usually when patients have glomerulonephritis, they're hypertensive. Just throw it in there. Okay, so that's why this pressure is normal. Lab, normal chemistry group, creatinine's normal. Urinalysis shows a little protein, but the microscopy is negative. And what did I tell you about microscopy being normal? The chance that this person has glomerulonephritis is extremely, extremely low. So if I said to you, if the next question is, oh, by the way, so, and another thing is urine protein creatinine ratio is 0.4 grams per gram. Okay, so how much, in a 24-hour urine collection, how much is that? 400. I heard that, right? So 400 milligrams, right? So because a gram is normal, a gram of creatinine, by the way, right? So the second part is the creatinine is G, Second G is creatinine. So they expect you to know that 1,000 milligrams is normal. So this person is spilling 400 milligrams per day, which is above the 150 we talked about. Usually when bad things happen in the kidney, it's usually above a gram. I'm just giving you some hints. So if you see on the boards 0.4, 0.3, usually don't think, oh my God, something bad's going on. And again, the boards does not trick you, okay? They don't. They just want you to know. Okay, so what's the next step? Remember now, this is different than the first case where renal biopsy was done because I said, if you miss this person's in trouble. But that person had red cell counts, right? Red cells, this person has nothing, right? And no protein, no significant protein. So that would be off. That would be wrong, renal biopsy. Right, split proteinuria quantification. And they're trying to get you to know about orthostatic proteinuria, which I can let you read about at your leisure, which is a benign condition.
You say hypertension was more for the cardiac?
Well, just for glomerular injury, acute glomerulonephritis, for example, like it's really unusual for someone to come in with a creatinine of 5 or 6 and have Wegener's, and their blood should be normal, or lupus nephritis, or most of these patients who have active glomerulonephritis, they're usually hypertensive. Not always; it's not 100%, but it's very high. Okay. I don't know what happened.
Which side were you on?
I don't know.
Did you get past this?
Well, we're 70 or 60 something. I don't know. Oh yeah, I got stuck somewhere. Did I finish? Oh no, maybe not. Is that the end?
Was this then?
Let's see. Yep, that was it then. Okay,
Oh.
That was pretty good. That was faster than I thought. Okay. So questions. We're going to end a little early. Talk a little fast. Questions for me. We got a few more minutes. Actually took them out. Some questions last year was over. 15 minutes early. Okay, but it's very, very important, team, to make sure that you understand the importance of urine analysis and dipstick. I can't overemphasize this. I would argue that every patient that comes into the hospital should have a urine specimen. It's $18. It's a very small amount of money. And the reason for that is because if your urine is normal, no protein, no blood, and the microscopy is negative, assuming it's truly negative, the chance that that person has something going on, it doesn't matter, systemic disorder. Let's say someone comes in with a pulmonary syndrome and they got a hematologic abnormality. The chance that the kidneys are involved in a systemic disease with no protein, no blood is exceedingly low. And so what happens is a lot of times people don't think about the urine, and they get a urine, a week later they're in the hospital, they've had 3 Foleys, now the nurse pulls it out, now they have blood in the urine because of, Foley is traumatic, and all this kind of stuff. And then you don't know, is the blood real or is it not real? We can't do red cell casts because nobody knows what they look like, and then you order all these serologies and we spend a lot of money. Whereas if ordering like 80 serologies, and this happens to me as well, we have to order all these tests because the initial UA wasn't done. Nobody knows if it was normal at presentation, and it would be a very good and simple and cheap test to order on almost the majority of cases that come in the hospital. I think they're going to be there for a while, especially a clean catch, because it really does rule out a lot of bad diseases or associations of why they're in the hospital. For example, take another scenario. You see this all the time, right? Someone comes in and their urine when they come in the hospital is normal, no blood, no protein, right? And now, 2 weeks later, their creatinine bumps and it's 1.8, and they've been on 2 different antibiotics. Well, maybe they do have an interstitial nephritis, and you can compare the urine from when they came in to now. Now they have white cells in the urine. Is it interstitial nephritis? Is it not interstitial nephritis? It would be really, really helpful to know what the initial urine was. So I think that it's really important. The UAs are really important to know what you're looking at. And I just think that it's a really cheap test, and it should be something that you should consider on almost all the patients that are coming questions? This is fun. I mean, I'm open to anything, by the way. You can ask me anything. It's kind of fun. Remember that when someone comes in with renal failure, you have to know why. Always ask yourself why. If someone's magnesium is low, I can get the medical students, no offense. We can get the medical to replace it. And anybody could do that. I mean, but that's not the answer, guys, right? The answer is anytime you have an abnormality, okay, always ask yourself, why is it low? Now, you may not know the answer. I don't always know the answer, but I always ask the question, why? Okay, and that's how you don't miss things. People miss things when they don't ask the question, why? Someone's K is low, right? If you see a dialysis patient with a low potassium, that's unusual. Okay, I always think of diarrhea. Or some of the other medical students, I'm picking on the medical students today, it's fine. I had medical students getting KXLA when it was not, they shouldn't have got, whatever. Or too much KXLA, whatever. But a person on renal failure or on dialysis shouldn't have low K. Always ask yourself why. And the same thing when the creatinine's up. You have to ask yourself, why is this creatinine up? And if you don't know the answer, I'm going to be very blunt. You better get someone who does, whether it's nephrology or someone else. Because when you miss things, missing things is bad in medicine. And I can tell you that the one thing that we as nephrologists get in most trouble is when we miss things. Like, and the thing that you get most in trouble for missing is glomerulonephritis. So always, and it doesn't matter which kind, by the way. It could be MPGN, Wegener's, anti-GBA antibodies, either lupus. Those are the bad, because let's say you're diabetic. Let's say the creatinine last year was 2, and now it's 4. Let's say it's from progression of diabetes, right? Okay, well, what could you have done about it? Nothing. Okay, but if it was 2 last year, now it's 4 because it's hydro and you missed the tumor, or it's a superimposed glomerulonephritis that potentially could be treated. That's when you get in trouble. That's when patients get angry, systems get upset, et cetera, et cetera. So always ask the question why. And this is not just for renal, this is everything. Just another educational tool. Don't worry about the main reason why someone comes in the hospital. Worry about 2 through 10. When I do educational rounds, I always tell people, so imagine someone comes in the hospital nowadays, you're in Hackensack, Mecca, right? The chance that a person has a creatinine of 3 and doesn't have a nephrologist on board, that doesn't have to be me, by the way, anybody, right? Any nephrologist is pretty unusual, right? So if they come in with acute kidney injury, you have to learn, okay? Learn with the expert, but the creatinine of 3, the nephrologist is going to figure that out. But where things get missed, where quality of care gets hindered is when you don't worry about 2 to 10. Meaning, oh God, I forgot to order eye drops. Oh, I forgot to order their DVT prophylaxis. Oh, I don't know why their hemoglobin was 10.6. I just blew that off because I was worried about the creatinine. Well, maybe the hemoglobin of 10.6 with a creatinine of 3 is myeloma. Okay, always work up and worry about problem number 2 through 10 or 2 to 8. You can learn by number 1, but it's unusual. Some comes in with a brain tumor. What's the likelihood they're not going to get into surgery involved? It's pretty low. Okay, or a neurologist, right? But that neurologist, you may forget to order their clonidine. They were hypertensive, and now they're going to hypertensive crisis. This is just a quality issue, has nothing to do with recurrence, but it kind of goes along the same theme. Always ask the question why. Okay, some diseases that present with glomerulonephritis. Name some. So we talked about red cell CAS and red cells. Usually not. Well, it can. So I would say that's in the border, in the middle range. And hepatitis C is associated with MPGN. Okay, hepatitis C is, so if you have a patient with hepatitis C and you don't treat it, they're at risk to develop membranoproliferative glomerulonephritis. So a lot of MPGNs that you see are associated with hepatitis C. Okay, and they do present with hematuria, but I would say it's in the middle. I've seen MPGNs without hematuria, but it's certainly so it's in the middle of the road game. The bad glomerulonephritis, lupus, okay? So for the boards, if you have a patient with lupus nephritis, I guarantee, I have never seen a question on the boards. I know there's a type 5 of lupus. It's called membranous. So when you do a biopsy of patients with lupus, there's type 1, type 2, type 3, type 4, type 5. They all will present with blood except 5, which is membranous. It's one of the causes of nephrotic range proteinuria. But again, they're not here to get trick you guys. So I have never seen an internal medicine board question, okay, where they don't present it with blood. Okay, so lupus nephritis, it's going to be blood. It's going to be an active proliferative GN. So let's say, for example, you get a question on the boards and the urine protein to creatinine ratio is 0.2 per gram, which is only 200 milligrams, and the urine shows no red cells. I don't care what the question, I don't even, when I do renal questions, and that's, I should come in one day, Mary Grace, I should present an hour lecture, how I can answer questions on the boards without reading the question, just based on the lab results. It's actually very fun. And I can cross off usually 2 or 3 answers because I know what they're looking for. I know how to answer the board's questions. And so I just cross off I don't even read, you don't have to read the question. There are some questions that you get a mix at where I don't even read the question. I get it right just based on the urine. I don't even read the question. Because I know, well, this disease can't present with protein, can't present with blood, and you can get the mix-up questions right. We should do that one week if we have a little time. If you have, well, we can actually go through. It's fascinating. It's very fun. I like, no, they never present a case on the boards with no blood, and it's lupus. They just cross it off. And you will not see a case. For example, Wegener's. They will never present a case of Wegener's without blood in the urine. So it doesn't matter what. And that's why for the first case, I actually gave you a diabetic. I gave you the patient with a diabetes. It was a little bit of a trick, but the diabetes, they're supposed to be on an ACE inhibitor, and the creatinine's normal, okay? And I gave you all this kind of fluffy stuff, but what the most important part was the urine. You never blow off a urine on the boards that shows blood or red cell cast or hemoglobin cast. Never. That is a real emergency, and you have to know the diseases that present with that kind of sediment on the urine. So that's why it doesn't matter what the story was. I can tell you, if you read that question and you saw red cells in the urine, the answer is a renal biopsy because there's nothing else that you need to do. You have to do that. So you don't have to read the question. That's all wasting time. So anyway, questions. I'll shut up for a few minutes of questions.
Can the urine protein creatinine ratio identify light chains?
It can, yeah, it will, but not as much. So the answer is it may not. It may not identify them as much. So therefore, that's a good question. So when I do urine looking for light chains, I always do urine immunoelectrophoresis. You'll never see me order a protein electrophoresis, very rarely, because I want to know if they're monoclonal or not. So if they're not monoclonal, once they're monoclonal, guess who I call? Hematology. That's now the diagnosis, the disease is in their realm in terms of treating myeloma, or if it's amyloid, or if it's light chain deposition disease, or heavy chain deposition disease. That's all there. Even when we do a biopsy, that's their call in terms of treating which chemo agent they will give. So when I order looking for paraproteinemia, anybody with a fungus, I always order 24-hour urine for immunoelectrophoresis. It gets, and if that's negative, then I just don't worry about it. But if you had a patient with no myeloma, that's why you'll see when they go back to see the oncologist, they will always order 24-hour urines because sometimes the urine protein creatinine ratio will not pick up the degree of proteinuria. What's a good question? Yes.
So you're seeing a patient follow up in the clinic from the hospital. They had acute infection, it's a proteinuria on the urinalysis. You just repeat that first, of course, before sending out for other testing. So
say that again. So a patient was from the clinic, someone from clinic, yeah.
So they had like one isolated hospital urinalysis with proteinuria. Would you just repeat that in the clinic before then doing further testing?
So it depends on how much. So what I do is I repeat it and I do a spot urine protein to creatinine ratio. The standard is if you think it's real, you got to do the 24-hour urine the first time. That's what you're supposed to do. It depends on the scenario. If I thought it was a very hemoconcentrated specimen, look at the urine osmolality. Oh, that's another thing, right? Because so your specific gravity can be thrown off by a lot of different things. And if you look at a lot of the board's questions or any exam questions nowadays, specific gravity is usually not something they throw in there. They'll do urine osmolality. Okay. So what's your urine osmolality? And so because the dipstick of the osmolality can be, specific gravity can be somewhat subjective, but urine osmolality, when you measure it, it gives you a good indication of what the volume status of the patient is. So your urine osmolality can vary between 50 and 1200. Okay. So if I'm in a euvolemic state, the urine osmolality should be 285 like blood. Okay. If I drink, otherwise everything gets thrown off, right? So if I drink a lot of water, my urine osmolality is going to be low, right? So if I don't drink a lot of water and I pee, my urine osmolality is going to be high. So the general, when we look at urines, I'll often order urine osmolality to kind of get a sense of what the state of the patient is. But I just thought out from a specific gravity standpoint, in terms of like if that person was very dehydrated and they had a little bit of proteinuria, I'm like, okay, maybe the proteinuria was falsely elevated because it was so concentrated. So I'll repeat it then. A good question. Anything else? Another 3 minutes. If not, enjoy the rest of your day and thank you for having me, guys. It's always fun. Thank you for this. Bye. Thank you. Yeah.
Thank you.
Oh, thank you. Very good.